if the AIDS epidemic continues to spread unabated in the way that it has spread over the last 25 years, the consequences are virtually unimaginable. And the implications of that for social stability, for economic activity, for political stability are profound. What we're trying to do with Dignitas is create a long-term, viable response to the AIDS crisis in the developing world.
Having worked with MSF for so many years and seeing what was going on in communities where informal and formal groups were responding in their communities, gathering firewood, trying to get some kind of childcare, helping with agriculture, helping each other really try and survive AIDS. The premise of Dignitas is how do you harness that energy, organize it, train it, and then link it to a healthcare system. If you can do that, you can tap a huge resource that exists already, that's already working all around the world.
The only way that we can get through this as a community is if we do it literally together.
As I'm talking, we have 240 members within Umoyo community-based support organization.
Some of them fear that if I'm positive, then I'm dying. And when they tell us that, we try to convince them that being positive is not the end of everything.
Previously, when we had no Dignitas here, we did not even know how to dress wounds from these patients. Mm-hmm. And after Dignitas trained these volunteers and the message that they give us, it is very helpful.
Is she having any drainage?
The model when we started really consisted of 5 areas that we had to scale up. Counseling and testing, treatment with antiretrovirals, prevention of mother-to-child transmission, prevention education, and finally developing a network of home-based care workers to support people in their communities.
The community-based care approach that we've developed and are developing is a radical departure from the way in which healthcare has been approached in much of the developing world. We're working with communities to help them help themselves. It's a very simple and practical approach to simple, practical, but deadly real problems. In a small hamlet of houses, some 40 kilometers away from the main hospital in Zamba, I talked with a woman who had AIDS and tuberculosis, and who, unsurprisingly, wanted to live. Her name was Charity, and she had 2 children. As we talked, 3 other women gathered, and within minutes, a clutch of 21 smiling, giggling children also collected around us. Why are there so many children without mothers? Where are the mothers?
Yes, most of these children don't have mothers and fathers. They passed away.
Yeah.
Yes.
Yeah. And of AIDS?
Yes.
Yeah. 1/3 of the children in that small village were without parents, orphaned because of AIDS. If Charity did not get treatment, then 7 orphans would become 9 orphans. That is 42% of the children in the village. And how they would survive was anyone's guess.
She has been sick for 3 years and some months now. She was once treated for TB. She finished the treatment. The things did not improve after the treatment. She's willing to go to the hospital, but she doesn't have transport as of now.
So Pearson, are you running this?
The major problem, as I've said, that is transport. Our total population is 36,500 something, which means we've got about 90 villages to cover.
Transport it's a huge issue. Instead of sending patients to Zomba Central Hospital, where they have to pay 240 kwacha to get there and back, bringing the services here to Damazi and to other healthcare centers is a smarter way of doing it.
Now these people can travel 4 kilometers as opposed to 60 kilometers to get their drugs. And all of a sudden you have a decentralized system where people can access treatment quite simply.
These are your boys. Come. So, can you ask him, how often does he go and work to make money?
He says 3 times in a week he has to go in the villages, look for some pieceworks to get some money.
And Batu doesn't go to school on those days, obviously.
Obviously, those days he has to be off.
Right. So basically he's working so his mother can go to the hospital.
Yeah, sure.
Right. Okay. Wow. Well, he's a very good boy for working for his mother.
Yeah, sure.
And the sooner you get on treatment, the sooner he can go back to school regularly.
Yeah,
And I hope you get to the hospital and get started on treatment.
Yeah, she will go.
Yeah, she will go. All right. If Charity can get treatment, it suddenly means that she's well. She then also becomes a person who's able to contribute actively to her community and help others.
There are thousands and thousands of people that have returned to their communities, that are raising their children, that are back working in their economies, farming their fields. I've literally seen people wheeled in by wheelbarrow and 3 months later are back at work. One thing that speaks really well to the model is the fact that we've accomplished our programmatic goals of phase 1, 2 years ahead of schedule and $5 million under budget.
What we're doing in Malawi is figuring out the practical elements of an approach to community-based care that can actually treat people and actually affect the dynamics of the epidemic. The success of community-based care in Malawi opens up the possibility of actually treating everyone who's HIV positive, and not simply those people who are HIV positive and sick. And if you can do that, then what it means is you can break the back of transmission, and then you break the back of the epidemic. It's not simply about the direct relief of suffering, which obviously has its own value. It is that, but it is also helping communities to come together to deal effectively with the AIDS epidemic. Now we're looking within the Zomba district of Malawi to expand the focus beyond HIV to, for example, tuberculosis and to, for example, other major priority health needs like malaria.
If we're going to go to the next level, we need significantly more resources. It's not about the implementation. The implementation will have smaller teams doing it. We really need to build the operational support, research support, and the dissemination support capacity of the organization.
We are working in Malawi to develop this model, and we're doing so with a view to taking that learning and sharing it with others in other countries around the world. We need help, we need resources to continue doing what we're doing, to continue researching, to continue building the research networks internationally, and to continue building the policy networks internationally, where we can actually share meaningfully our experience and our knowledge with others.